We're now going to start with the new lecture that I just posted from Kines on Gait. So let me bring Gait up here. Switch screens. Get rid of that. And we'll share screen. All right. Can everyone see the Gait lecture? Yes, I assume. Yeah. Okay, cool. All right, when I say Gait, and again, we're switching to Kines, I just want to stress that again. When I say Gait, what does Gait mean?
The way someone walks.
Good. That's as simple as it gets. It's the, I guess not fancy because it's only 4 letters, but the fancy term for walking, right? So how can we analyze Gait? There are all kinds of ways we can analyze Gait. I think I sent you guys the video of doing motion capture for the Injustice game. That we use a lot of these motion capture devices for that. We have motion capture. We have pressure plates like this one up here in the upper, this one here in the upper, let me left. That's where we're at. We can record somebody walking on a treadmill. The good news is, again, we all have a recording device now in our pocket. Don't record a person without first getting what? Consent, yeah. Right? You're like, man, you know, Truman's got a funky gait. I want to send this to all my friends. No, don't do that. Right? You've got to make sure you get consent first. Right? So you want to make sure, hey, I want to show you what I'm seeing when you're walking. Can I record you real quick? Just a 5 or 10 second clip so we can watch it together. You'll be amazed, and you know, we've done this a couple times where I'll record some of you guys walking, and then when you look at yourself walking, you're like, wait, I walk like that? Because we don't think about it. When I walk completely like a freaking penguin. My toes are completely out. I don't think about it, but that's the way I walk. When I see it, I'm like, man, that's bad. But it's a habit of way I've walked. So we can do all kinds of things to kind of measure how people walk, what they do, where their feet are, and stuff like that. So let's look at a couple terms here. Are there any terms on here that you do not understand?
Antalgic.
Antalgic. What does antalgic mean?
Painful.
What'd you say? Painful, is that what you said?
Yeah.
Yeah, okay, I couldn't hear you. I was like, I thought that you said, yeah, painful. So Antalgic Gate, we're going to find out about Antalgic Gate in a little bit, because if you ever put that on any of my soap notes, I'm going to take my little squishy ball and I'm going to bounce it off the back of your forehead. Wait, back of your forehead? Front of your forehead. So Antalgic Gate is a no-no. We'll talk about why in a little bit. So Antalgic just means painful gait. Who has a painful gait? Almost all of us at some point in the day, right? We almost all have an Antalgic gait at some point. I know yesterday I was, after going out running for whatever reason, I twisted my ankle a little bit and I had an Antalgic gait for a little bit. So I saw vaulting. Well, we're going to show a vaulting gait, but a vaulting gait is exactly like it sounds. The patient's going to bring their hips really high in order to clear things. And Trendelenburg. All right, so we're going to talk about that too. But what is Trendelenburg? You guys remember that from last semester with Dr. Johnson?
I know it's where one side of someone's hip is weak and they kind of dip in.
There you go. That's the simplest answer for it. Hip dip. Anthony's exactly right. So that would be where if I was standing up here and you said, lift your right leg, and I lift my right leg and it goes wonk. That's called a hip dip or a Trendelenburg dip. And we'll talk about how that affects gait. All right, so the gait cycle. The gait cycle involves stride length. Stride length is the time from one foot touching the floor to this time that the same foot touches the floor again. So typically when we talk stride, we're talking side, so right stride, left stride, right side, stride, left stride. A step is from when your right foot touches until your left foot touches. Does that make sense? So stride is from when my right foot lifts up to the other time the right foot touches down. Step is when right, left, right, left, right, left, right, left. Are we clear on that? Just making sure. Okay. Stance phase is when feet are in contact with the ground, whether it's 1 foot or 2 foot. Stance phase is 60% of your gait cycle versus swing phase, which means something's not in contact with the ground. That's about 40%. I would be really, and I actually had a book once that was funny. One of the books I had for this class said stance phase was 60% and swing phase was 50%. You got up the math there, right? Because if one's 60, the other has to be 40. You can't have more than 100%. I'm just saying. So when we're talking about a stance phase or a support phase, because stance and support, so these two terms here are often used interchangeably, almost like the RLA versus traditional. Support means something's on the ground. A single support or a single stance phase would be when only 1 foot's on the ground. Double support would be when both feet are on the ground. And then non or no support or no stance is when neither foot is in the contact with the ground. And there's only one time that happens, and that's if a patient is running, right? It'd look really weird if your feet aren't touching the ground while you're walking, wouldn't it? I'd be like, wait, what's happening here? How are you doing that? You're a wizard, Harry. Floating, right? You're a wizard, Harry. So stance and support go kind of hand in hand. So if I'm asking you don't walk, we float, right? If I'm asking you a question, say, a single support phase during gait is where 1 foot touches. A double support, 2 foot. Non-support or no support, running is the only time you can get that. So you must understand normal locomotion or gait before you understand pathological gait or bad gait. Gait is probably one of the most important activities of daily living. If we can't walk most of the time, we can't do most of the stuff we can do, right? And also a lot of times, being able to walk or not being able to walk may be a sign of if a person actually qualifies for disability or not, right? Because if a person works in a job where they have to walk and stand and now they can't, that could potentially qualify them for disability. It is a repetitive and cyclical movement pattern, meaning that it goes in cycles. And if you understand normal gait and understand how it looks, you can look at abnormal gait and pick up on what's going wrong. So we talked about stance phase, contact with the ground, weight acceptance, and single limb support is in stance phase. Swing phase, foot is off the ground, it's where the leg is going forward. There are 3 phases of swing phase: pre-swing, mid-swing, and terminal swing. So pre-swing is when the leg's getting ready to go. Mid-swing is as the leg's coming through, and terminal swing is when the foot's getting ready to touch again. So we covered step and stride already. I just want to beat these until the horse is dead. Step is 1 foot until the other foot. Stride is the same foot contacting 2 times. So here's looking at what happens. Here's looking at you, kid. Here's what happens during gait, right? So if I'm walking, the first thing that happens, I come through, my heel touches the ground. I'm going to slowly transition my hip forward until my foot is flat. And then I'm going to start bringing this leg through. As I bring that leg through, this leg here is going to go back into extension. And then that leg's going to touch. And then we just repeat the cycle. This leg lifts up, starts swinging, comes around, and then touches again. If you can draw this, even if you don't get the terms, it can help you answer most of your gait questions. Because it's pretty easy to understand that initial contact is when the foot first touches the ground, right? And when you are foot flat, it's when your foot is, well, flat on the ground, right? If you're in a terminal stance, your foot's getting ready to lift up, right? So this is kind of looking through it as you go through the leg, right? This is breaking it down, looking at one side for stance phase and then looking at the same side for swing phase. I put a lot of pictures on here because Dr. Johnson said some of you guys had a little trouble with understanding normalized gait, so I wanted to make sure that I hit it pretty hard. So this is the fun part. Don't you guys love that there are two different terms for gait, traditional and RLA?
No.
At least you're honest. All right, so understand when you're looking at these two. RLA looks at things from a neuro perspective. Traditional looks at things from an MSK. When I say MSK, when I say MSK, what does MSK mean? Does anyone know?
Musculoskeletal.
Yeah, musculoskeletal. Good. Right? So RLA, so Ranchos Los Amigos is a place in California that deals with a lot of neuro problems with patients. So they traditionally deal more on the neuro side. And if you look at the wordings are a little bit more kind of neurological, right? Initial contact, loading response, mid stance, terminal stance, pre-swing. Whereas if you look at musculoskeletal, the traditional, heel strike makes sense, right? Well, it's the time that my heel does what? Strikes the ground. Well, foot flat then makes sense. It's when my foot is flat on the ground. Mid stance is when I'm getting ready to move off of foot flat. Heel off. Oh, wait, my foot's heel is now off the ground. The heel's off the ground. And then toe off is when my toe gets to go off the ground. I find traditional is easier for students to understand. And this takes a little bit of work. Would you guys agree with that?
Yes.
Yeah? Okay, good. Now for me, for whatever reason, this made sense. RLA makes sense to me. And I think it's because I like big words and it makes me feel smart. But when you're looking at it, it's the same thing, right? An initial contact would be when my foot first touches the ground. A loading response is when I'm putting most of my weight down through that leg. Good news is mid stance on both of them is the same. Terminal stance is the last time kind of my foot's out there, and pre-swings when I'm getting ready to swing the leg through. I know it's difficult, but if you can at least kind of get those, it will help you in answering questions. The number one question I get with students about the boards is, are the boards going to ask me questions where the question is in traditional and the answers are in RLA? Yes. There will be questions like that. I'm sorry that I have to tell you that, but there will be questions like that, where they'll say, looking at a patient from an RLA perspective, their initial contact is clean, their loading response is clean, but they're having problems where the toe comes off. What is that term in the RLA gait cycle? Well, toe off is pre-swing, and you have to understand it. Yeah. Danielle's like, what? We will go through a couple of those questions. Don't worry. Like gait cycling, I hit pretty hard in test prep. So you just need to understand, for me right now, you just have to get the difference between them, or, you know, where they fall. If you can memorize this box here, you can answer questions on my test, because it's literally going to be, for my test, initial contact in the RLA scale equates to what in the traditional scale? And the answer then would be heel strike. Okay, so that's what you have to know for me right now. That's the baby step. We're going to take big boy steps next semester when we start talking about neuro patients. Baby steps, Bob, baby steps. So here's another kind of looking at it through the different stance and swing phase. I don't like this chart, but some of the students did like this last semester when I showed it to them. To me, this is really way confusing. But if this helps you kind of understand the difference between a stance and a swing phase, more power to you. It doesn't help me at all. The pictures like this help me make more sense of it than anything. So here's kind of looking at stride length versus step length, right? looking at the base of support. We're going to talk about all that. What can influence our gait? Our age, our pain, our strength, our range of motion, our walking speed, and our fitness level. All of that kind of comes into play. When we're talking about stride or step length, right? The normal length is 1.33 meters. Most people are about 1.3 meters, somewhere in that range. Walking base, how wide our feet are, it's about 0.9 centimeters or about a full centimeter. Foot progression, again, I'm not going to ask you this, so don't totally, your board's not going to ask you the progression angle. I just put that in there to show that your ankle has a pretty decent range of motion when it's walking. About 6.8 degrees. Walking speed. For most people, it's about 1.5 or 1.4 to 1.5 meters per second. So a normal walking speed, if you're doing it in miles per hour, if you wanted to walk comfortably on a treadmill, what would you put the miles per hour at on the treadmill? Has anyone done this? What's a comfortable walking speed?
Like 3.0?
Okay, so I hear 3.0. For more healthy people, 3 is comfortable.
I'd say like 2.5 for
Yeah, so I usually go 2 to 2.5 for older people, right? So for healthy people, 3 to 4 is possible. Like Daniela's going 4. She's like chugging along. She gets 15-minute walking mile. She's moving, right? 0 is a normal, exactly. 0 is my walking speed too, exactly. You got it. Normal people will take about 100 to 125 steps per minute. Small amounts of abnormalities are acceptable. Large amounts are not. So asymmetry is meaning abnormalities. What are our 3 tasks of gait? What are our 3 kind of jobs of our legs? Well, there has to be weight acceptance, meaning can the leg bear weight? Can a single leg bear weight? That's single limb support. And then can the leg that's not bearing weight move forward? Leg advancement. We're going to talk about that next semester with stroke patients. A lot of the problem with stroke patients is the weight acceptance and the leg advancement. They don't have the ability to move those legs or bear weight on them as much. So we already kind of covered the RLA versus traditional. This breaks it down in another form here. I have that on there in case you want to look at it this way. I don't care how you do it, just learn it. Here's a picture breaking it down for you. More pictures, more gooder. When we walk, we have a displacement. When a displacement means a change, right? When we walk, we have a vertical or an up and down displacement of about 2 inches. Now, if your boards ask you in centimeters, how much is 2 inches in centimeters? About
5.
About 5 centimeters, right? So 2 inches or 5 centimeters is usually what I say for vertical displacement. Your highest point is at mid stance, when you have the one leg fully extended. The lowest point is when you're at heel strike, when you're kind of stepping down. The good news is your horizontal displacement moving side to side is, guess what? 2 inches or 5 centimeters. That should make you guys feel a little bit of breather relief that I don't have to remember a ton of numbers. If you can remember 2 inches for vertical and horizontal displacement, you've got those answers. So that's where our body shifts side to side. Who do you think shifts side to side more, men or women?
woman.
Why?
Your hips.
Hips. Good. It all relates back to the hips. Remember, the hips don't lie. Now, when you kind of move in this, so it says forms more of a sine wave. It's not true like you're going right, and then you're going left, and then you're going right, and then you're going left, right? when you move and your hips are moving side to side, it moves in a wave format. So it's not just true, I'm automatically to the right, I'm automatically to the left, I'm automatically to the right, I'm automatically to the left. You kind of move through that motion almost like a snake. Or as I like to think of them, they're not snakes, they're danger noodles. It makes them so much more friendly. The nope rope, exactly. Lateral pelvic tilt. Lateral pelvic tilt occurs when removed from one leg, such as during toe-off. So when you're on one leg, there's an amount of tilt that happens. That's actually what creates your vertical displacement, is that pelvis shifting up and down. So remember, anterior posterior tilt is going forward and backwards, right? Lateral tilt is rocking on one butt cheek or the other. Does that make sense? Just think about that when you're walking. You will kind of tilt your pelvis to the side while you're walking. So what happens? What motions occur? At the foot, there's a lot of motion occurring at the first metatarsal phalangeal joint. So that's at your big toe. When you're doing toe off, there's a lot of motion that occurs there. Most of your rear foot or hind foot motion is based on movement at the posterior aspect of the heel, so kind of rocking on that heel. The ankle has a lot of motion. The ankle will actually go through almost full dorsiflexion to full plantar flexion. So that means the ankle requires a lot of motion. The knee will go from about 0, meaning full extension, to about 60 degrees. And we'll cover this more when we talk about the actual motion of the knee. But during normal gait, the knee goes from about 0 to 60 during the full cycle of gait. And then it'll go back to 0 when you're back to mid-stance again. So that means you do need to have kind of full knee extension and functional range of motion to get to 60 degrees of knee flexion. Why did my degree sign not come there? Whatever. The hip goes from about 0 to 30 in both directions. So when I'm extended back like this, when I'm straight up and down, and when I'm forward, I have a variance of about 30 degrees. So that means I go into about 30 degrees of flexion, about 30 degrees of extension.
So I'm sorry, Mr. McKeever, these measurements are just for like during gait, correct?
Just during normalized gait, yes. Right, just normal walking on the floor. And again, don't get totally hung up on them quite yet, because Riley, we're going to cover them in each individual joint segment when we get to them, talking about what are the requirements for it, if that makes sense.
Okay.
This is more talking so that you get the idea of how it works. Hyperextension, you spend about 50% of the gait cycle in. So that means you have to be able to get the foot backwards. Now that becomes a problem for certain patients. If your patient has an anterior hip replacement, total hip replacement, guess what motion is contraindicated? Extension. So here's extension going backwards. That's a contraindicated motion. So that means they're taking only, they're going to step to that foot, step to that. They're never going to go where that leg's back. That's going to slow their gait cycle down and also increase their energy expenditure. And then we talked about the pelvis. There's a small amount of pelvic motion going on. There's slight anterior posterior nutation and counter nutation and counter nutation going on. Don't worry about those words yet. We'll hit them in pelvis. But basically rocking back and forth of the pelvis. And then again, we have that lateral tilt going on, giving us our vertical displacement. The main reason I wanted this slide on here is this shows you there's a lot going on in the body during gait. And we didn't even talk about the upper body. This is just at the lower body. So muscle actions during gait. I put this on here because there's been a lot of questions on your boards lately about what happens at what muscle during what point of gait. I can already see Riley's head exploding at that. I made it as simple and as easy as possible, right? So when I get initial contact, Initial contact is when my foot hits the ground. My ankle dorsiflexors are going to try to maintain my foot in kind of neutral in order for my foot to hit evenly. My knee extensors are going to slowly contract concentrically to bring my knee into extension. And then they're going to stop doing extension and lock into a eccentric hold so that I don't hyperextend. I know this looks like a lot. We're just talking through it right now. Don't freak out. I'm not going to drill you on this yet. The hip flexors are isometrically active, meaning they're holding everything stable. But then they're going to start contracting eccentrically to decrease hip flexion. Now we're getting into loading response. We're starting to move forward, right? The ankle dorsiflexors are going to concentrically or eccentrically contract to lower the foot down. Remember, we're in heel strike. Now the foot's going to start lowering down to go to foot flat. And allow the toes to touch the floor. Those knee extensors will continue to contract eccentrically to allow a small bit of knee flexion, but more importantly, to restrict hyperextension. And then the hip extensors are going to start contracting concentrically to allow the hip to come forward. Mid stance. Now my legs kind of almost straight up and down, right? My ankle dorsiflexors deactivate, and then my plantar flexors are going to start contracting. First of all, to contract eccentrically to slow everything coming through and control the tibia. And if you don't have functional plantar flexors, that tibia will become unstable during gait and may rotate. The knee extensors continue to contract concentrically to hold the knee into extension. And the hip extensors start contracting to bring the leg backwards. Terminal stance is where we get to that end part, right? Where we're starting to pick that foot up. Oh, wrong way. Good job, Mr. McKeever. You're going to confuse everybody, if you're not already confused enough as it is. My leg's back here now, right? My plantar flexors change from eccentric to concentric to pull my foot up so that I can eventually lift it off. The knee extensors are holding tight. They're saying, nope, my knee's not going to buckle. I'm not going to go into hyperextension. And then my hip extensors, my butt muscles, are contracting to pull that leg backwards. I know this looks hard, but when you draw it out, it's not as bad. And then we go into the swing phase for that leg. Pre-swing, the plantar flexors pull the toes up to get the toes up and off the floor so that we can swing through. The hip and the knee extensors contract concentrically to pull the leg back. And then we start going through initial swings. So now the dorsiflexors start pulling through, so I'm starting to get to where I can strike down. Hip and knee flexors contract concentrically, pulling me through. Mid-swing, dorsiflexors change from contracting this way to isometrically to hold my foot in space. And my legs swinging through. And in terminal swing, I'm getting ready to land back into initial contact. My dorsiflexors stop pulling upwards and start kind of holding it isometrically so my foot can eventually roll through again. Hamstrings contract eccentrically, slow down knee extension, hip flexors contract concentrically. That is a lot of stuff. I really tried to make it as simple as possible into like 3 slides. So the next question I'm going to get is, Mr. McKeever, how much do I have to know for this class? I'm not going to get into whether a muscle is eccentric. I know, Diane, that's why I'm getting it right now. Relax. I'm not going to hit you so much as if a muscle is going eccentric or concentric. I am going to test you more on if you were in terminal swing, where your leg's kind of up off. So here's one leg. This leg's on the floor. So here's my floor. You're in terminal swing, so you're getting ready to put that heel down. What position should the foot be in order for the heel to strike down? What position should that foot be in? Should it be in dorsiflexion or plantar flexion?
Dorsiflexion.
Dorsiflexion. Good. If you know that, then you know that what muscles have to be contracting. The dorsiflexors, right? Whether it's eccentric, concentric, or isometrically, they have to be doing something in order to hold that foot into dorsiflexion. Does that make sense? with this foot here that's in stance phase, because my knee is straight, what muscles have to be holding me into straightness? Well, my knee extensors, right? Because whether they're contracting eccentrically, concentrically, or isometrically, if they're not doing some form of contraction, my knee's not going to stay straight. Does that make sense? I'm stepping down even from this whole list, just going.
Mr. McKeever, is
Yep.
that when your knee buckles when it doesn't contract correctly?
Right. So if I'm in a phase where I step out and my knee kind of goes bonk, drops out, right? Bonk, my knee, it gives. The reason it's giving is because my quads aren't holding me in that extension, right? If my quads hold me in extension, that knee will never buckle. That's a great question, right? And guess who ends up having a lot of problems with knee buckling? Patients that have had ACL repairs, total knee replacements, because what muscles suffered an injury? The quads, right? They either have to move the quad tendon out of the way to get to the ACL, or if they did a total knee replacement, they had to cut through it. So does that make sense? They'll get a lot of knee buckling going on. You've got to strengthen those quads so that it stays nice and straight. All right, I've lost all of you now. It's great. I love it. People's heads are exploding. Dogs and cats living together. Mass hysteria. So the main thing, I know, Truman's awake. The main thing I want you to get out of this class is talking about joint motion and energy expenditure. When we're working with patients, one of the main things we have to work on them with, because again, we're not dealing with healthy patients, we're dealing with unhealthy patients, is working on energy conservation. When you get to your boards, I'm going to tell you guys, there are two main things that the boards worry about: safety and energy conservation, because those are the two main things our patients have problems with. So you have to understand that the body center of mass is about the height of the person's navel in the center of the body, right? So right about there. Muscle activation. When they are walking, timing is critical. Eccentric motion is probably, or eccentric contractions are probably the most critical to gait. You can get a lot of problems when the muscles can't slow down motions or can't hold motions. At the foot and ankle, there has to be stability at that foot and ankle joint. Did anyone ever sprain their ankle really bad and then walk around and like 15 minutes later you're walking around and you kind of twerk the ankle the way that you already hurt it? Right? Yeah, and you're like, God dang, why'd I do that again? We've lost a little stability in that ankle. And when that happens, stability is so important at that ankle that if you don't pay attention, you'll kind of externally rotate or do whatever you need to do to get that foot tweaked again. So stability is huge there. Your knee and your hip, your large muscle groups, your quads, your hamstrings, your glutes, your iliopsoas are super important to be not only strong, but have normal range of motion in order to have normalized gait. If you don't have strong quads, you're going to get that buckling. If you don't have strong hamstrings, you may not be able to flex the knee to clear the foot. So all of that's going to come into play. But one thing we always forget about is the arms. The reciprocal arm swing is there to further enhance energy conservation. When I step forward with the right leg, right? If I'm going forward with the right leg, the left arm goes back, and then vice versa. Why does that happen? Why do we get reciprocal arm swing?
Counterbalance.
What's that I heard?
Counterbalance.
Counterbalance. Good, right? And Christina said balance as well. Exactly. There's a certain amount of counterbalance going on in order to keep your pelvis going in the right direction. How many of you guys have seen the mall walkers that are at the mall doing this? Right? And they're really chugging. They got their little water bottles. I don't like when they do that, because they think they're doing it to increase strength. But when you have your arms bent like that, aren't you in a kind of constant state of tension? Right? There's not a relaxed state for your arms. And your arms are better at conserving energy if you're in a relaxed state. So then that also begs, if a patient has something like crutches or a walker, are they going to use more energy walking? Yeah, right? Because they're not able to do that reciprocal arm swing anymore. So now the only way they can conserve energy is with their legs. So how do they do it? They take shorter steps. And then they're like, well, I'm conserving energy because I'm taking shorter steps, but now it takes more steps to get places. So they've used more energy in the long run, right? So arm swing is really important. More disabled, exactly, Joe. It frequently happens in Parkinson's disease because Parkinson's disease kind of slows up all the motion of the body. And it's interesting, if you can get a Parkinson's patient to do more arm swing, their gait improves. It's pretty wild that this happens, right? Does anyone know what a Parkinson's patient walks like?
Shuffling gait.
What's that?
Shuffling gait.
Good, right? So like, I'm gonna switch cameras here again real quick. I like this fact that I've got like a virtual studio here, right? So a Parkinson's patient, when they're walking, right? Their feet are not very much process, right? But man, they're just kind of shuffling along. And when I do this, my arms aren't moving at all. Let me tilt this up a little bit. There we go. Right? So when I'm doing this, my arms aren't moving at all. If you get them to accentuate their arms and moving their arms with them, so, okay, take a step, and get their arms moving, all of a sudden they'll take bigger steps. And the Parkinson's patient's like, you're a wizard, Harry. And you're like, no, I'm just an awesome therapist. That being said, actually, now that I said that, be careful calling yourself a therapist. Some PTs do not like PTAs calling themselves therapists. I'm just warning you. Every PT I've ever encountered considers a PTA a therapist because you are performing therapy. But some PTs don't like that. So just saying, be careful. Age-related changes in gait. So let's think about a kid. For those of you that have kids, they have what's called almost a cowboy gait. Their legs are wider apart, right? Their cadence is faster, but they don't go as far. Why don't they go as far as an adult?
Short legs.
Short legs, yeah, right? Some of you actually still have that problem. I'm just kidding. I'm just kidding. Ha ha, come on, that was kind of funny. Right? Stride length. Some of you are going, I feel attacked, Mr. McKeever. How dare you? Their stride length is shorter because their legs are shorter. Initial contact with the floor is more foot flat than heel strike. So when they walk, they tend to kind of slap their feet down. Right? And you can hear that in the house, right? Those of you that have kids, when they go running around the house, you tell them, stop stomping. And in reality, that's just kind of the way kids do things until they're trained to go heel strike, roll through, toe off, heel strike, roll through, toe off. Do any of you guys that run, when you run, you definitely hear your gait getting louder? Like your feet start slapping a little more than normal? I know mine do. When I run, I tend to not do as well with heel strike, roll through, toe off as I do when I walk. Yeah, especially when you're fatigued. Good, trimming, yeah, right? It happens, especially longer in the run. Yeah. And then when it happens, well, good, Bianca. But I'm going to use Truman and myself as an example. When we start getting that way, Truman, we're actually using more energy doing that, which is funny because we're actually making ourselves more tired. It's kind of a vicious cycle, though, wouldn't you say? And then they have short, choppy steps, no reciprocal arm swing. When I was in school, and I don't know, maybe some of you that are parents or maybe some of you that are still kids yourselves that just recently went through school, do they still teach you gait cycling in gym class in elementary school? Do they even have that in gym anymore? I don't think.
I worked with preschoolers and kindergartners, and they call it wellness, not PE anymore. And she would pay close attention to like, oh, are they able to cross the midline? And like did a very like planned progression of how they learned how to do things.
Good. I would give her a hug if I could. Good. Because we're losing PE, we're losing a lot of that. Why are we losing so much of that education in the school? Number one, funding. But why else?
Lawyers?
What's that?
Lawyers, maybe?
Could be. Okay, yeah, I guess. Right? The other reason is we're focused on standardized testing, right? Schools are so worried about being in certain percentiles on standardized testing. They'd rather have them in the classroom getting standardized testing training than they would about getting them healthier. When I was in Denmark, I actually worked for a school district over there, and hold on to your seats here. Elementary school kids spent half their day on the playground. So they went to school for about 7 hours a day, and about 3.5 of that was on the playground, up to about 5th grade. And now 5th grade's pretty old. Guess what they find when they do that? Right, kids' job is to play, right, Riley, right? And so when they spend time out there, guess what else they develop? Social skills. In Denmark, Sweden, a lot of them have that. Because and guess what else the kids, they have a lower rate of in Denmark? They have a lower rate of what, do you think?
Child obesity.
Child obesity. Yep. Right, so working with your kids on this is not a bad thing, right? I'm afraid if I ever had a kid, that poor kid would be tortured. Like, what are you doing? You're walking on your toes. Get on those heels. What are you doing? Just imagine myself as a neurotic father. One quick thing, because the first thing you see in the old folks here is fear of falling. When a child falls, so here's my little child. Yay! When a child falls, which way do children tend to fall? Forwards or backwards?
On their bottoms?
Yeah.
Forward? Oh.
No, kids actually fall on their butt. Believe it or not, think about it when you were going to school. Like if any of you went roller skating or whatever, because that's usually the number one way you break your tailbone, we fall backwards. And then when we become adults, now I'm old, right? Now I'm an adult. Yeah, I'm so happy. Now I fall on my face. Right? Now let's think about it. Do you think we could possibly save some fractures if we learn to fall on our butts more often? Maybe. I mean, I don't know. It's just a thought. Because our butts got some cushion back there, at least most of us. I know I've got plenty back there to land on. Some of us probably not as much. But if I land on my butt, I'm less likely to break things than if I'm landing on my arms. But yeah, it's because kids' center of balance is posteriorly shifted. Ours is anteriorly shifted. So we tend to fall forwards as adults. That's why also when you have a kid's walker, the part of the walker that's like the walker part is backwards. Kid's walker is reversed from what an adult walker is because kids fall backwards. So adults, what happens and changes their gait? Well, they start being afraid of falling. It's the number one reason adults say they don't walk.
Oh, sorry. That's okay.
Hello. So adults have fear of falling. We're gonna take a break in about 5 minutes after this, or actually 2 minutes after this. So adults have a fear of falling. They do, right? It increases as you get older. And so as that fear of falling increases, they stop walking as much. Because they stop walking as much, their muscle mass goes down. They tend to walk slower because they're worried about falling. They spend more time standing in a stance phase than they do in swing phase. Their wider base support comes back. It's funny, when we're a kid, we have kind of a cowboy gait where their legs are wide. By the time we become an adult or an older folk, we have cowboy gait comes back. I always think that it's funny that, you know, in kids, we were in diapers and we had wide base of support. And then we become an old person, we end up back in diapers with a wide base of support. It's just that the circle of life. So researchers found a relationship and a possible early screen for dementia looking at gait analysis. They have found that people that have poor gait are more likely to develop dementia. Does that sound interesting to anyone else? I mean, that's really interesting to me, that there's a link between brain health and walking. Like, that blows my mind. Gait apraxia may show up first, and we're going to talk about apraxia versus ataxia in a slide forward, so don't totally freak out if you don't recognize those words yet. Be careful when you're looking at Professor Google. There's a lot of articles out there. There's a lot of charts. There's a lot of national media, peer-reviewed journals. If you quote any research to your patients, make sure that research is peer-reviewed, that it's in a legitimate journal. The Journal of Naturopathic Medicine isn't necessarily always the best journal to get stuff from because they don't peer review. Just saying. They also think vaccines are Bill Gates chipping us. But that's a fact. All right, let's take a quick break because I think I'm losing some of you guys. I'm seeing some of you frying out. So let's take a 10-minute, come back at about 15 recording. So we last talked about age changes in gait. So now we're going to move on from age changes and start talking about some different type of gait abnormalities. So this photographer up here in the corner is the first time it was ever captured on camera. They actually caught what it looks like for a shark to step on a Lego. I mean, that was a rare moment. For any of you that have either children or have godchildren or family members that have Legos, you know the experience of either stepping on a Lego or a Hot Wheel. It's the most fun thing in the world. It's usually in the middle of the night when you're trying to go to the bathroom. So what can happen and what can affect gait? Well, pain can affect gait. Permanent or temporary muscle neurological symptoms can cause it. Abnormalities in gait increase energy expenditure, which usually reduces the amount of walking people do. People will compensate for gait abnormalities, meaning they'll start cheating. And once you start cheating, sometimes that cheating will become habit. Motions linked at one segment of the link kinetic chain can influence motions in the other. So if you're having problems with heel strike, it can have problems in your stance phase as well. So Antalgic gait, you used to see a lot in notes. Patient presented today with Antalgic gait pattern. Antalgic gait pattern doesn't tell me anything. It just tells me the patient was in pain, right? In truth, Antalgic gait pattern is an observable reduction in motion at the painful joint and asymmetry in gait parameters. Fantastic. That still doesn't tell me anything, right? The main thing is don't use this in your SOAP notes without further qualifying it. So what do I mean by that? If Anthony was to turn me in a SOAP note that said patient presented with Antalgic gait today, secondary to increased pain in the posterior popliteal fossa during stance phase, that tells me something. Whereas if he just says patient had Antalgic gait, when? How? Why? To what extent? Right? You see the difference in the the writing there? One gives you very specifics about when the Antalgic gait happened and kind of what's the precipitating event that's causing it, versus just saying, yeah, they're walking painful today, right? Or patient's gait was Antalgic today with heel strike. Okay, that still tells me something. But just saying the patient's gait is Antalgic tells me nothing. I don't know. I just know they're walking painfully. Doesn't really help me. And remember, your job when you're writing notes is, number one, to inform your PTs. And number two, if somebody follows you, they should be able to duplicate your treatment. So lateral trunk bending. So all of these, I have gait videos. I'm not going to play the gait videos today because that takes up way too much time. I did that before and it took me 4 hours to get through this lecture. The videos are there for you. Trendelenburg gait is also known as Gluteus Medius gait. Why is it called Gluteus Medius gait? Well, guess what the muscle that's usually weak in this is? Can you guess?
Gluteus medius.
Yeah, it's amazing. Mind blown, right? So lateral trunk bending goes along with contralateral pelvic drop. These are tied hand in hand. So lateral trunk bending or Gluteus Medius gait or Waddling Gate goes along with this because contralateral pelvic drop is in standing. Whereas when it's, what's that?
Oh, I'm sorry. Did you say Gluteus Medius gait is also Trendelenburg?
Is also Trendelenburg gait.
Okay.
Yes. Or waddling is the other term for it. Right? The penguin is an excellent example from the Batman series, right? Waddling Gate. Anyway, I watched too many movies or cartoons, I guess. So what happens with Trendelenburg sign? So down here we have the Trendelenburg sign, which again is in stance phase. So if I shift my camera again, when I have Trendelenburg sign, you're going to have me lift one of my legs. Now, when I lift one of my legs, what should happen is this contralateral, the opposite side, right? The opposite side's glute med should contract and hold. So I should be able to hold my leg up off the ground. With a Trendelenburg sign, when you have me lift that foot up, my pelvis drops. So if I'm lifting my right leg, it drops back down. That is a left Trendelenburg problem because it's the left glute med. So if the leg drops, it's the opposite side that's the problem. Does that make sense? So again, so let's say I lift up my left leg and my pelvis drops. Which glute med is my problem?
The right?
Posterior right.
Correct, yes. So if whatever side you have me lift up, if it drops, it's the opposite side that's the problem. Okay? So that's sign. Sign is in standing. Trendelenburg gait is when I walk, when I go through swing phase, remember I have to lift that pelvis, right, to clear the foot. You'll see it drops. So I'm going to step through. And you see how it's kind of a waddling gait pattern? Up, drop, up, drop, up, drop. So if you see that drop is happening on my right side again, the problem is my left glute med. So my left glute med is not able to hold me in this type pattern here. Does that make sense? So Trendelenburg, good. So left Trendelenburg gait is a problem with the left glute med. The right side is dropping. So if you get a question that asks you, your patient has left Trendelenburg sign, that means the right side is dropping. Does that make sense?
I'm confused. I thought it was, wait, if you lift up your left leg and it drops on that side, it's the opposite side that is affected?
Yes.
So saying if the left leg has Trendelenburg, that means that that's the dip on that side, which would be the right that's affected?
Yes.
Okay. And same goes for the right.
Exactly. Yep. Same goes for the opposite. You got it.
Okay.
I know it's difficult. The main thing you need to understand for your boards is your boards will say, oh, I'm not back to my normal camera, am I? Your boards will say your patient has a right pelvic drop in swing phase. What muscle is weak? If you have a right pelvic drop, meaning that right side is dropping down, it's the left glute med. Does that clear it up? That's how your board questions are going to be worded.
So like, for example, in this picture, the left leg is the swinging leg that's happening, and you see the left hip is dipping, but it's the right side that's...
It's this side that's affected.
Got it.
Now, she is compensating by using her trunk. Do you see that? Because her trunk's way leaned over, right? So I can try to compensate with my QL. And instead of letting the glute med hold it, use the QL to kind of pull my hip up. And that will be what will lead to eventually them getting that kind of waddling or penguin style gait. So we're going to work that left glute, in this case here, right? So this is her left side here. This is her right side. So her left is dropping. So we're going to work that right glute med hard. So we're going to do a lot of abduction exercises to strengthen that side. Does that make sense? I know this one's probably the most difficult concept to grasp. All right, posterior trunk lean. And the other thing you'll see here is a lot of the gaits are named for the way the trunk is leaning. So posterior trunk lean or gluteus maximus gait, because my trunk is over my butt. During early stance phase or early swing phase of the gait cycle, the patient leans posteriorly to move the gravity behind the hip. So when they're walking, they're basically kind of swaying back and going back over it. Now, that can be caused by a couple different problems. That can be caused by tight butt muscles and tight hamstrings, right? Because it's kind of pulling you backwards. Or it could be weak anterior, something like that. You're exactly, that's pretty close, yep. Right? It could also be the weak anterior muscle. So if one side is tight, it could lead to that gait. Or if the other side is stretched weak, it could lead to that gait. In this case. So when I've got posterior gait or posterior trunk lean, when I walk, right, so it's going to be during stance phase, I'm going to kind of lean back over that back of the leg. So again, when I walk, which does kind of look like the hustle, doesn't it, a little bit? You're right. So I'm leaning back when I'm in stance phase, dropping back, dropping back. So that's posterior trunk lean. If I have anterior trunk lean, because my body is leaning over the front of my body, it's also called quadriceps gait, because I'm leaning over the quadriceps. That's kind of like this lady here, but she's got really exaggerated quadriceps gait. So these could be tight, or all these muscles back here could be stretched weak. Motion seen in stance phase again. So in this case, when you see this, when I go to stance phase, I like to think of that one almost like a chicken style gait. So when I walk, I go to stance phase and lean forward. Right? Kind of looks like a chicken walking, doesn't it? So anterior lean gait. Excessive ankle plantar flexion, observed in both stance phase and swing phase. This is common with kids. So we're going to talk about what's called equinus gait. Does any of you have kids that walk like this? Where they walk on their toes? Let's see if we can.
Playgrounds.
What's that?
At a playground, I saw a couple kids walking like that.
Yeah, right. And interestingly enough, that's a normal childhood development. Sometimes they walk like that, but it can also be a sign of CP, cerebral palsy. But so now, if I have excessive plantar flexion and I'm going through swing phase, is it going to be hard to clear my foot?
Yeah.
Yeah. So what I'm going to have to do is vault my hips. So I'm going to have to lift my hips way high to clear that kind of toe dragging foot. Right? So vaulting can occur here. It can also occur when we talk about weak tibialis anterior. So they're trying to avoid dragging their toes. So excessive plantar flexion. How would you know if the problem, if you're like, okay, so they're vaulting, is my problem my tibialis anterior or is it my gastroc? How would you know that? What could you do? Instead of just watching them walk, what else could you do?
You could do manual muscle testing.
Muscle testing, good, right? Maybe you do a manual muscle test and you're like, dorsiflex, and they're like, I am. And then you're like, oh, let me feel your calf, and their calf feels like a rock because they're just that either frozen in that place or they're just really tight. And so their tibialis anterior at that point is like saying, I can't overcome that, right? Or their leg is nice and relaxed and you tell them dorsiflex and you get like an inch. And that could sign that that tibialis anterior is really weak, right? And then you go to put some pressure on it and they're like, burp, it breaks right away. You're not able to do any resistance on that tibiant. So yeah, this is going to tie right into manual muscle testing. Hip circumduction or swing leg, right? This is where they're going to, instead of Could do a home science test. Sure, absolutely. You could use that as a good test for it. It's not going to tell you if they have a blood clot, but definitely if you press down in that calf, you'll know if it's super tight, Joe, for sure. Because it'll feel like you're pressing into a rock. I have a kid that I treated back in a few years ago that literally was stuck in 70 degrees of plantar flexion because his calf was that tight. Literally, I was stretching on it by sitting on his toes. That's how much force I had to give in order to stretch his calf out. I couldn't just push on it. There was no pushing. I had to put like my whole body weight on the like plantar surface of his foot and sit down on his toes. It's kind of funny. Yeah, right? Well, the problem was mom didn't detect it and mom brought him in at 13. At that point, he's already frozen there, right? So circumduction, this is a problem with typical hip flexion, knee flexion, or ankle dorsiflexion. Again, trying to clear the foot. If you have problems with plantar flexion, you could go into circumduction as well. So this is where when they walk, instead of just kind of going heel toe like we normally would, they're going to do one of these. And try to swing their legs wide. That's because they can't get that hip flexion going when they're going to plant down. So they'll swing their leg out. And they get the same effect going on. Swing my leg out, heel straight. Circumduction is exactly like it sounds. Increased knee flexion is typically when we got problems with the knee itself, usually a contracture or knee pain, swelling, or they're post-surgical. You'll see during loading response or terminal phase, so when I'm in that phase where I'm getting ready to kind of get ready to come on the toe off, my knee's stuck in flexion. Right? So my base of support is going to drop way low. Right? Because if I'm here, I'm like, okay, so I'm loading response and I'm not straightening my knee. I'm going to be dropping as I walk. So that means we need to stretch the knee out. We're going to need to stretch that hamstring, stretch it, Hemi. Stretch a Hemi, and get the swelling down. How could we get swelling down? What could we put on the knee?
Ice.
Ice, good. Which other modality could we use?
Compression.
Okay, we can use some E-stim, good. Genu recurvatum, this is the one that hurts for me to demonstrate. This is also known as back knee gate. So recurvatum, right? Back knee gate. So this is when the patient goes into stance phase, the knee kind of snaps backwards. When you see somebody that has this gait pattern, it will be painful to you guys. The video I have about that is really painful looking. So again, when I go into stance phase here, so I plant down, I go into stance phase, what you'll see a lot of times is that kind of pop. And the knee will literally bend backwards. My knee won't bend backwards because I'm already kind of stuck in flexion. But they get this pop going on where it like literally pops backwards. And then you'll say to the patient, does that hurt? Due to hyperextension. Yep, Riley, that's exactly right. The patient will, you'll ask the patient, does that hurt? And they're like, not really, because they're so used to it. So that means that quad is not contracting either eccentrically or isometrically to hold that knee into extension. Does that make sense? Where it locks it at 0 rather than going that way. So we're going to work all of those knee muscles to kind of get that where they got neutral knee. If I go into hyperextension, do you think that's going to put all of my ligaments at risk for injury?
Oh, yeah.
Oh, yeah. I like that. Oh, yeah. Oh, yeah. Anyway. Steppage gate, also known as drop foot gate or tibialis anterior gate. Steppage gate is where I like to think of this almost like a horse, the way a horse walks. It's where they're going to really kind of flex the knee to clear the foot. So steppage gate, a lot of times what you'll see is when they're walking, they'll bring their knee, they'll hyperflex it in order to clear the foot, and they kind of kick out. So it kind of looks like a horse prancing to me, doesn't it? Maybe it's just me, but it kind of looks like a horse prancing. I know, right, Amanda? Who'd have known? So primarily when you have that steppage gait, the problem is they can't clear their foot. Could they also clear it by circumducting?
Yes.
Yeah, right? Could they do both? Mm-hmm. Yeah. You get a patient's doing like a steppage circumductive gait weird pattern. That's going to require a ton of energy and they're going to get tired walking. So foot slap is the one thing you'll know if the problem, you'll know the problem is tibialis anterior if you hear when they plant down. Because what happens is that foot hits heel strike and there's no control and it just slaps down. Slaps down, drop foot. Good, Joe, right? And so that's a problem. That's why they're doing that steppage gate, is to clear that foot. And sometimes they'll do that so that when they do that like kick out part, the foot goes into a little bit of dorsiflexion so that they can get into heel strike.
Are they going to have strong hip muscles from doing all that extra movement?
A lot of times they're going to have either strong or really tight hip muscles. Yep. And then also usually their their hamstrings are also usually going to be tight because they're flexing that knee so much that it just, they just like, when I walk, my legs hurt. Well, let's look. And they're walking and they walk like they're a prancing horse. And you're like, oh, well, that explains a lot. So gastroc or soleus gate, or what I call Lego gate, which is an antalgic gait pattern. This is where the person has typically a sore foot. And so you'll see them walking like this. Their other foot's planting the whole, anyone ever see somebody walk like this? Right? They're only touching down with that toes, lots of kids, right? And that's usually when they have a sore foot. They've stepped on something or their ankle's sore. So what you're trying to do is avoid putting any weight on that foot. So if you're trying to avoid weight, if it says the patient has a right gastroc gait pattern, which is a sore foot gait pattern, that means they're going to avoid right stance phase because they don't want to put weight on that foot. Does that make sense? Usually when you have an antalgic, I mean, you can't see my air quotes, an antalgic gait pattern, their stance phase on that side is going to be reduced because they don't want to weight bear on it. So if I had a right knee replacement, yep, sir, that's what I'm going to do right now, Dino. So if I've had a right knee replacement, or maybe I've had right ankle surgery, I'm going to probably end up with either a gastroc gate or, again, some of the doctors actually call it Lego gate or antalgic gate on that right side. When I have a problem on this right side, I'm going to not want to put any weight on it. So that means that I'm going to reduce my stance phase on that side. I'm going to increase my stance phase on the other side and increase the swing phase on this side to avoid putting any weight on it. So when I take a step, right? So I may take a normal step with this foot if my right side's affected. So I'll take a normal step with this foot, plant down, and only hop kind of to where it's at. Because I only want to put my foot on the ground for a small period of time. Does that make sense? Boom, hop, hop. Because I'm trying to stop weight bearing.
Is that for, I'm sorry, was that for the Lego gate or?
Yeah, Lego gate, yep.
Okay.
Yeah.
Would a splint do anything for that? Sleeping splint?
Could, sure. Right? What else could do it is addressing what's causing the pain, right? Like, what if my problem is I have a plantar ulcer or something like that? So that's why I'm not putting my foot down, because I've got an ulcer on the bottom of my foot. We could dress the ulcer and put a pad down there, and that would also address it. Do you see how that could work? And again, that could be diabetic. Most diabetic ulcers occur on the bottom of your feet because we can't feel them. What else could cause that? Sprained ankle, right? Because I want to avoid putting weight on that ankle after I've sprained it. Gout, good, Jason. If I have a sprained ankle, what could I put on it to help it maybe?
Bandage.
Bandage, wrap it, right? Wear a brace if I have a brace. But again, I find if I give a patient a brace, they're going to overuse it. If I give them a wrap, they'll only use it when they need it. And Jason brought up gout. What is gout?
Like
Too
crystal?
much. too much uric acid in your body, so it starts just releasing it into your joints, which
Yeah.
turn into little crystals. And I had gout. It was terrible. That's how I walked for like 3 days before I decided to go to the ER.
Yeah, gout is a systemic. It's a systemic buildup of uric acid, right? That causes inflammation in localized joints, right? Most people get it in their big toe is the primary place you get it, but it could be the whole foot. It could be in the. I've seen gout in the knee. Like that was probably the worst case I saw. The dude's knee was like this just giant red ball from the gout. A lot of it's from eating processed meats, like going to Subway way too much or going to Jersey Mike's or one of them. Right? Tart cherry, yeah, cherry juice does help with that a little bit, but try finding cherry juice in the store anymore, unless you go to like Whole Foods or places like that. But yeah, so gout could definitely do it, right? And they'll give you medication, colchicine usually for it. Waddling Gate. So Waddling Gate, we talked a little bit back here in, where were we at? Back here with lateral trunk bending, right? But this Waddling Gate's a little different. So remember I had mentioned briefly the other day, I mentioned ALS, right? Do you remember me mentioning ALS or Lou Gehrig's disease? ALS goes distal to proximal. So when your muscles start wasting away, they start in the extremities and waste to the middle. The kind of flip side to that is muscular dystrophy, specifically Duchenne's muscular dystrophy, but pretty much all of them. Becker's ties into it as well. In that, the patient wastes away from proximal to distal. So the first thing, and usually, so this is a older adult, right? This disease is of adults, whereas muscular dystrophy is of who? Kids.
Kids.
Yeah, Stephen Hawking said ALS. So with Duchenne's, a lot of times my core wastes away first. So when I talk about my core, that also includes all my core pelvic musculature. So if that's weak, when I walk, I'm going to have to bring the camera up a little bit more and I keep adjusting it. You guys don't know what I go through to give you these examples. When I walk, I almost stay in a posterior pelvic tilt when I walk. And I walk like that. And you might ask, well, why do they walk like that? Well, what they're doing is instead of relying on their muscles during gait, they're literally just hanging on all of those ligaments in the hips and the knees to allow them to walk. And this is a very pronounced, if you see a kid walking across the playground like this, unless they're playing cowboy, they've probably got muscular dystrophy. And unfortunately, that's not a good thing for them to have. Because usually by like teenage years, they're in a wheelchair.
Is cerebral palsy the same thing?
So it's not really. Cerebral palsy is a disorder of the brain. Whereas with muscular dystrophy, it's a disorder of the actual actin and myosin of the muscle. Same thing with actual ALS, it's a disorder of the actin and myosin of the muscle.
So with the muscular dystrophy, it wouldn't be good to give them some things like walkers for their hands? It's better to just keep them walking on 2 feet?
Ideally, keep them walking as much as possible, but eventually they're going to need a walker, and then eventually they're going to need a wheelchair. So, you know, it's going to be a progression. There's not a cure right now for MD, so eventually they're going to be wheelchair bound. It's just the unfortunate way. Most of them I see by 15, they're in a wheelchair. They can live after that, but their muscles are going to continue to waste like ALS. With cerebral palsy, the problem is not necessarily, and I have a great video on that from Zach Anner, who's one of the spokespeople for the Cerebral Palsy Foundation. He does a great scene about that because I'll have to find the video and post it for you guys. He'll talk about it. He says, people ask me, what's wrong with my legs? And I tell them, there's nothing wrong with my legs. My brain is broken. My legs are fine. So the problem with cerebral palsy is the brain's not actually talking to the legs and telling them what to do because the brain's got damage. That was a good question, though. Spasticity can happen as well. With spasticity, you can lead to scissoring gait. So you just mentioned cerebral palsy. Cerebral palsy happens a lot with scissoring gait, and same thing with equinus gait. So scissoring gait is where the legs are going to cross midline when they walk. This can also be somebody trying to look fancy when they're at the club, right? I'm just going to sway when I walk, right? But if you've got a true scissoring gait, your legs are literally like this when you walk. Can you imagine how much energy that takes to walk where your legs are constantly stuck like that? Whew. And then, like I said, I already mentioned that equinus gait, but a true equinus gait, both legs are kind of stuck up on their toe. Oh my God, that's actually hurt my ankle. So up on their toes constantly when they're walking. Okay, clear. Bring back to the other camera again. Hemiplegic gait. Who's going to have a hemiplegic gait? So this one over here is a hemiplegic gait.
Strokes.
Strokes, good. Right, hemiplegic, half paralyzed. So typically a stroke is going to affect one side of the body, and they're going to be kind of typically dragging that foot that's affected, and the arm that's affected just going to kind of curl up into a contraction. I don't want to hit ataxic and apraxic yet because that's going to confuse you guys today. So we'll hit that tomorrow. Ataxic just means they're having problems with the brain, and we'll talk about that more in depth. So skip that one for right now. Because if I go into that, that's going to take 40 minutes. I will come back to that. Bradykinesia, where they talked about, Parkinson's gait, right? That festination of gait where their feet are really shuffling and they freeze. Overpronator versus oversupinator versus neutral gait. Do any of you know? Yeah, tomorrow, exactly, John. Actually, I have a whole lesson planned on ataxic versus apraxia. So, do any of you know if you overpronate when you run?
I do.
Any of you had a gait analysis?
Yeah, I do.
Okay, so Joe says yeah, right? So some pronation is normal, right? So some where the foot, remember pronation, foot's kind of turned inward, supination, the foot's kind of turned outward. Some pronation is normal. We usually are neutral to pronator runners. About 90% of the population trends to a pronator to an overpronator. That's walking on the inside of the foot. Versus 10% are supinators. Or as one of my instructors call them, the supinators, because they eat a lot of supper. I don't know. They walk on the outside of the foot. There are plenty of orthotics and shoes and everything for overpronators. Well, why do you think that is? Well, because 90% of the population has it. So they'll make pronation shoes, pronation control shoes. If only 10% of the population has either underpronation or oversupination, they don't make a lot of shoes for them. That I know of, there's only right now actually three. I just found another one. I forget what the name of the third one is, but there's only 2 brands that I know that make oversupinator shoes. New Balance, because they want everyone to buy their shoes, and they're also the shoes of middle-aged men. And then also Asics makes one. And I usually buy the Asics ones because I'm actually a supinator. I walk on the outsides of my foot. How can you tell what can be a quick check to see what type of if you're an overpronator or an oversupinator? What could you look at?
I think
Your shoes?
Shoes. Yep. So let me hold on. I can run it. Oh, ow. Oh yeah. Here we go. Here's one of my old pairs. So, first of all, looking at the front, look at the size of the inside here versus the size of the outside out here. Definitely more compressed out there. But then if I turn it up, do you see the tread on the outside? How it's almost all gone? Even the middle is kind of almost all gone, but these are old shoes. These are my grass mowing shoes, right? But I've still got tread in here. If you look at it from the back, the outside's worn out. So yeah, you can look at your shoe and kind of go, oh, yeah, I'm probably an overpronator or oversupinator. I like the Dr. Scholl's kiosks just for that. I am an oversupinator. I walk on the outsides of my feet, but I also walk toe out, so that doesn't make it any better. I should have saw physical therapy when I was a kid, is what I'm saying. The Dr. Scholl's, that machine that they have in the like at Walmart or at any of the drugstores, is actually good for that, as long as you don't mind getting, you know, fungal growth from whoever else stepped on that machine. But it's really good at giving you a foot map of your foot. Hopefully, I'm going to see. I wanted to borrow the pressure plate from UNLV so we can take a look at everyone's kind of plantar surface when they walk in. So hopefully they'll loan it to me. I asked to borrow it real quick for a day, so we can do that during lab and take a look at who's got overpronation versus oversupination. The other thing you can do with patients is get a long piece of like brown paper, like packing paper, roll it out, and put down some baby powder on it, and then have them walk. Supination is on the lateral aspect of the foot. Yes, pronation is on the internal aspect of the foot. And then neutral foot kind of goes right down the middle. That makes sense, Brooke?
Yes.
So supination, neutral, pronation. And you guys are like, wait, Dr. Johnson said we didn't supinate at the feet. Yes, you do. Leg length discrepancy. You were going to talk about this, and we're actually going to measure this. And leg length discrepancy, we can have either an actual leg length discrepancy or an apparent leg length discrepancy. An actual means there's a bony problem. Actual means there's a bone problem. One bone is longer than the others. This can be muscular, or it could be pelvic. It could be low back. There's a bunch of reasons why you could look like you have one leg longer than the other. So apparent means looks like. Apparent versus true or actual leg length discrepancy. This is sometimes called true leg length. So when you measure this, we're going to have a whole technique for this, but for true leg length, we go from the ASIS to the medial malleolus. We take our tape measure, and I have my little barely long one. You like my tape measure? Isn't my tape measure great? And you measure from the ASIS down to the medial malleolus, and then you do the same thing from the other ASIS down to the medial malleolus. Then if we're going to measure apparent, we're going to measure from the umbilicus, which is the other term for belly button, down to the medial malleolus, and then down to the other medial malleolus. And then we're going to compare our findings. A mild leg length discrepancy, I don't have it written on here, but is less than 3 inches. It can be corrected if they have it by using a shoe lift. A moderate leg length discrepancy is 3 to 5 inches. We're going to have to look at how to fix things. What's causing it? Is it a muscular or is it a bony? If it's bony, there's not much we can do other than helping them kind of compensate for it. If you have a marked where you have a 5-inch or more, the most I've seen, there was a patient that actually is a kid that was 16 that was in our clinic in Pennsylvania that had an 8-inch leg length discrepancy. Think of that for a second. Right? 8 inches. Size of a good sized trout, 8-inch leg length discrepancy. They had to go in and surgically repair that. So what they did is they went in and broke his leg and pinned the other one and took out a chunk of bone. So they basically shortened them. The only thing that can happen there is orthopedic intervention. So what do you have to know about this? You have to know how to measure. So actual or true, ASIS to medial mal, apparent, umbilicus to medial mal. And then what can we correct with a shoe lift? Less than a 3-inch correction or a mild leg length discrepancy. Most of these down here are going to have to see an orthopedic doc to figure out what they're going to have to do about it. All right, So gait patterns. You are not going to learn these in this class, but these are your gait patterns with assisted devices. You're going to learn these in Dr. Sokel's class. If you do not understand them, please come to me. These are important to understand. You have not gotten here with her yet. You will get here, but these you will learn in rehab. I just put them on here so you can see what they are. Okay, so Dr. Sokel will cover these with you. Dr. S. I promise you, because I put them in that class and she has them. Weight-bearing status is important with these. You have to understand how much weight a person can put on their leg. If they're having surgery, if the doc's limited them. Non-weight-bearing means exactly what it sounds. They can put 0%, that's a zero, honest, 0% on that leg. Partial weight-bearing, I hate. I saw a doctor says they could put 5% of the weight on that foot. Boy. Or the best was 37% partial weight bearing. Brooke, if you were to estimate how much 37% with me, would you just give up? Like, honestly, how would you figure out what 37% weight bearing for me is?
I wouldn't be able, I don't know.
Yeah. Oh, I bet he had a chuckle writing that too, Joe. So the technical way you do that is you have a person stand on two scales and see how much weight they put on each leg and then reduce the one by that percentage. I hate that. Docs are getting away from this partial weight bearing. They're either non-weight bearing, toe touch weight bearing, or weight bearing as tolerated. Force plate, yep, exactly. Toe touch weight bearing or touchdown weight bearing, which are pretty similar, are exactly like they sound. You can put your toe down and use it for balance, and that's it. I tell my patients with these two, imagine that you're stepping on an egg and you don't want to crack it. So you're just putting your foot down to where you can touch the egg but not crack it. Weight bearing as tolerated means as much weight as the patient can put down. And then full weight bearing is what we all are. We're all full weight bearing people. We can walk on our legs normally. Negotiating stairs. The golden rule, when you have an injured leg, up with the good, down with the bad. Good goes to heaven, bad goes to hell. So if I have an injured right leg, my right leg is injured, I had a total knee replacement on my right side. When I go up the stairs, I am going to go up with my left leg and come down the stairs with my right leg. Good goes to heaven, bad goes to hell. Does that make sense?
Why do you go down with the bad leg?
Good. That's a great question. So let me switch real quick. Switch videos here again. Used to be video dice. Start video. So imagine I'm going downstairs and my right leg is my affected side. If I go down with that left leg, I have to hold all of my weight on that right leg while I lower that left leg down. Versus if this is my affected leg, my right leg is my affected leg, I can hold my weight on my good leg, lower and slowly down, and as soon as I touch that heel, bring that other leg down. Does that make sense?
Yes.
That's the hard one to get. You're like, that doesn't make any sense, Mr. McKeever. You're still going down with the leg that's affected. But it's all about control. Like most of the world. It's all about the control.
Does it also have to deal with the flexion of the bad leg going down?
Yep, it can. Yeah, for sure.
Okay.
For sure. Yeah, you may not be able to flex the knee. Now, if my hip's affected, I may have flexion in the knee, but I don't have flexion of the hip. Right? So yeah, definitely. If you're going up with crutches, use the handrail on the side of the injured limb if you can. With both crutches in the opposite hand. The non-involved leg goes up first with crutches. But actually, you know what? Even with crutches, get rid of that. I don't know why the book says that. Don't do that. No. Bad book. I took that from the book. That's a bad book. Always up with the good. Always up with the good. So we'll go over this. We will actually practice going up and down stairs with devices. So don't worry about it. Whenever you are going up and down stairs with the patient, there is only one place you should be standing with that patient. That is down the stairs from them. Whether they are going up or whether they are going down. Why is that?
Gravity.
Yes, gravity. If they're going to fall, they aren't going to fall upstairs. Now, somebody in here is going to go, like Stephanie's going to say, I fell upstairs once. Okay, great. How many times did you fall upstairs? Once versus 50 times down the stairs, right? If you're going to fall, you're going to fall down this twice. Okay. You're going to fall down the stairs. Oh, Brooke, we got to work on some skills there, man. I'm just telling you. Okay, let's give you a total knee replacement. Now you'll fall down the stairs. Trust me. We always want to be below the patient so that we can catch them. If they kind of tilt and go forward, that's fine. That's what the gait belt's there for, right? But if we're behind them and we're up above them with the stairs and they start going down the stairs, yeah, that's not going to be fun because we're going to grab that gait belt and go for a ride with them, and we're both going to end up in a pile at the bottom of the stairs. Assistive devices, the main thing I want you to get out of here is know what an LRAD is. LRAD is least restrictive assisted device. LRAD is what most PTs, patients, they'll say, ambulate patient with LRAD. The PT is then telling you, you get to pick the assistive device to use, PTA. Good job. I trust you. And then you pick the least restrictive. This list down here is least restrictive to kind of, or most restrictive, so most restrictive to least restrictive. So parallel bars are the most restrictive. It's the answer on your boards. Pick it. It's probably the right answer. Walkers are the next most restrictive. Then we go to crutches. And I should fix this. This should say single crutch. Then we go to canes. Then we go to Hemi Walkers. Then we go to single crutches. Canes are the ones we really, I don't like giving any patient a cane because they use it wrong. Just watch House. House uses a cane wrong.
Can you tell me what a Hemi Walker is?
Sure. A Hemi Walker. Tested my drawing skills here. Kind of looks like this. It has a handle and it's on one side. It has lots of horsepower. Exactly, John. We actually have a couple of those at school. I'll grab a picture of it and I'll post it so you guys can see what it is. A Hemi Walker is a walker that's only one-sided. And the goal for that is somebody that has a stroke. Because if I have a stroke, I can't use a regular walker. So it's a one-sided walker. Hemi half walker. Does that make sense? I'll see if I can find a picture of it real quick because I think that's the last slide anyway.
Mr. McKeever?
Yep.
You said that if we see parallel bars on the test, that would be the MRID? That would be the most restrictive assisted device, but it's also the safest. Safest? Okay. Yeah, because you're in a safe space. You're trapped inside the parallel bars. There's nothing you can escape. It's considered the safest place to ambulate a patient. It is the most restrictive, or the MRAD, but it's also the safest. So again, the more you go less restrictive, the less safe you go. Right? If I go down to a single crutch, or a cane, I'm not very safe, right? Versus having a walker where I have two hands to help me. Or having the parallel bars where I not only have two hands, but I can lean on the bars if I need to lean on the bars. So a lot of questions will say, which is the most safe device to ambulate a patient in? If you say most safe and you go down and there's parallel bar down there, parallel bars is the answer, right? If it said walker and crutches and cane, then walker would be the most safe, right? The most restrictive assisted device is the safest. So it's good to know this order.
It is good to know the order. Yep. And I'm gonna beat this into you. Trust me.
Okay.
Don't you worry. You're gonna get Brooke you're gonna be sleeping one night and be sitting up going, parallel bars, walker, rolling walker, crutches.
I already do that.
You already do that. Yeah. So mainly my progression usually goes when I'm working. This will be kind of the last thing we cover. Goes parallel bars, standard walker, which is the 4-point walker. That's a K. That's a K, honest, I promise. Front-wheeled walker, crutches, and then canes. That's usually my progression that I do with my patients. And I almost never get down here to canes because they're usually not safe enough. And by the time I get to canes, I usually can just get rid of the assisted device because they can walk without it. Because I'm sorry, I forgot to put that on there. Like, this should be a single crutch or one. There we go, one. That bottom one should be one, John. You know, it's the loneliest number, right? All right, you survived. Let's stop recording.